Hello, this patient is a 67-year-old Hispanic female with a medical history of hypertension, hyperlipidemia, and obesity. Her chief complaint is I am here to check for my blood pressure. The patient reports monitoring her blood pressure at home on a regular basis. Her home log shows systolic blood pressure readings generally ranging from 130s to 150s in both the mornings and evening. She denies headache, dizziness, blurred vision, chest pain, palpitation, shortness of breath, or lower extremity swelling. She reports taking all of her medication as prescribed, including hydrochlorothiazide 50 milligrams daily, losartan 100 milligrams daily, amlodipine 10 milligrams daily, and atorvastatin 10 milligrams daily. She denies increased stress and states that she follows a balanced diet and walks for approximately 30 minutes every day. She denies use of tobacco, alcohol, or illicit drugs. Her past medical history is significant for hypertension, hyperlipidemia, and obesity. She has no history of diabetes, chronic kidney disease, stroke, or myocardial infarction, and she reports no recent hospitalization or um, any surgical history. When we saw her on Monday, her vitals are within normal, which is 122 over 65, which is within the recommended treatment goal. Her height is 4 feet and 11 inches, weight is 147 pounds with BMI of 29.7. The remainder of the physical examination was unremarkable. Cardiovascular examination demonstrated a regular rate and rhythm without murmur, rubs, or gallop. Lung sounds were clear bilaterally, and there were no peripheral edema. She appears well controlled in the office, but with consistently higher blood pressure readings documented at home. My primary diagnosis is resistant hypertension, although her office blood pressure is within normal. Her home blood pressure readings were elevated despite treatment with three antihypertensive medication at maximum tolerated doses, raising concern for resistant hypertension. The current ACCAHA guidance, written by McBoy and colleagues, 2024, um, they recommended confirming persistent hypertension with accurate out of office blood pressure measurement before making treatment changes. Before diagnosing resistant hypertension, pseudo resistance should be ruled out by confirming medication adherence, proper home blood pressure measurement technique, use of validated blood pressure monitor, and excluding the white coat effect with home or ambulatory blood pressure monitoring. The two other differential diagnoses that I have considered is first white coat syndrome or inaccurate blood pressure measurement. I considered white coat effects or inaccurate blood pressure measurement because there's a significant difference between the patient's blood pressure at home and the office. Although white coat hypertension typically refers to elevated office readings with normal reading, and any discrepancy between office and home measurement should prompt elevation of blood pressure technique and validation of the patient's home monitor. Um, Confirming accurate home measurement is recommended before diagnosing uncontrolled or resistant hypertension. The second that I consider is primary aldosteronism. It was considered because it is one of the most common secondary causes of resistant hypertension, although this patient does not report any symptoms suggestive of secondary cause and no laboratory abnormalities are currently available. Further evaluation would be appropriate if elevated blood pressure persistent after confirming accurate home measurements and medication adherence. Um, the plan for this patient is we will continue with her current medication regimen since her medic blood pressure at the office is at goal. I would reinforce proper home blood pressure monitoring by reviewing correct technique, including resting quietly for 5 minutes before checking blood pressure, sitting with both feet flat on the floor, supporting the arms at heart level, and avoiding caffeine or exercise for at least 30 minutes beforehand, and measuring blood pressure at same time each day. I would also ask the patient to bring her blood pressure um, monitor to check so it's accurate and can be compared with office equipment. If the discrepancy between office and home reading continues, then ambulatory blood pressure monitoring would be considered to confirm whether hypertension is truly uncontrolled. Lifestyle counseling would include continuing daily physical activity, reducing dietary sodium following the DASH diet, and encouraging additional weight loss to improve overall cardiovascular risk. For hyperlipidemia, we'll just continue with our atorvastatin 10 milligrams daily, and we'll obtain routine lipid monitoring and the next visit that we made for her. For follow up, we told her to come back in 1 month with her home blood pressure log and blood pressure monitor for review. If her home blood pressure remains elevated after continuing accurate measurement technique and medication adherence, I would evaluate for secondary causes of hypertension. According to the 2025 ACC AHA hypertension recommendation written by Jones and colleagues, because the patient is already taking an angiotensin receptor blocker, a calcium channel blocker, and thiazide diuretic, spironolactone 25 milligrams daily would be considered as the preferred fourth line agent if renal function and serum potassium are appropriate. Um, the patient was also educated on the importance of medication adherence, maintaining a heart healthy lifestyle, and recognizing symptoms that require immediate medical attention, including severe headache, chest pain, shortness of breath, or vision changes. This presentation is done. Thank you so much.